any clue the number of times that I've put it in here, how often you're going to see this in real life, and how this is something you really do need to recognize? Okay, she's lipemic. Her MCH is 63. Her MCHC is 83. I would also have taken cold agglutinin on this one if you thought that was it. That is also a possibility. But basically, the most likely cause is a lipemia. What would you do next? Plasma blank or plasma replacement. If you said it, you thought it was a cold agglutinin, which again is also a valid answer, what would you have done? Warm it up. And I'd take either one. Take either one of those answers. Or anything that makes any kind of sense that you notice that the indices didn't look human. That's all I'm looking for there, is that you noted that the indices were screwy. Okay. All right, Michael Johnson came in with a white count of 0.7. Low H&H, normal indices, very low platelet. Lymphocytes were 81%, everything else was, and the monos were 13. The segs were low. What's the most likely cause of this patient's condition? There are some things out there.
I would say it was some type of infection.
Okay. What? GI bleed. And it's not an infection, because what's his white count? 0.7. It's like absent. Yes.
Is it therapy-related anemia?
Therapy-related anemia, like go for that. GI bleed plus therapy. There you go, perfect. That's, yeah. She said that the patient's bleeding and he has no platelets because of the chemo. I'd have taken if you said leukemic, as long as you put in there that because his lymphs were 81%. Although he probably actually has myelogenous leukemia. Why the heck would I say that? His lymphs are through the roof. Why would I say he probably has myelogenous leukemia? What? No. Bruising can be all kinds of leukemia. Because he's on chemo. So the reason he's missing his segs is probably because the chemo we gave him was to wipe them out. Okay. One of the other things that you that I have on a lot of my case studies, what happens if I have a patient who comes into the hospital this morning with a white count of 74, slightly anemic, slightly low platelets. Tomorrow morning he comes down and he has a white count of 0.6. Is that something I would expect to see? What if he's a chemo patient? Is that something I'd expect to see? Yeah. We will see deltas like that, and a delta just is any value that differs from a previous day, and the computer marks it and says, hey, this ain't what we saw yesterday. Take a look at it. So it isn't uncommon for us to see someone come in with a high white count, and within just a day or two, their white count will be bottomed out. It will be nothing, less than 1,000. It's because the chemo's working, and then what we do is we watch it go back up. Some of these patients we call the alert value platelet, his platelet is 9. Woohoo! He's going up. Okay. What treatment would you recommend for Michael here? Probably transfusion of packed red blood cells, platelets possibly, although the new platelet limits I think are under 10, so that we don't transfuse platelets as often as we used to. But yeah, transfusion. Would you stop the chemo? A lot of times if it's drug-related anemia, we're going to stop the chemo, or we're going to stop the drug. Would we stop the chemo? Which is worse, the anemia or the cancer? The cancer. So what are we going to stop the drug? Lionel King came into the ER. Severe pain, shortness of breath. Physical exam revealed slight jaundice, hepatomegaly, and splenomegaly. He has a slightly elevated white count, low everything on his red stuff. Platelets were normal. Diff was basically normal except for the presence of 22 nucleated reds per 100 WBCs. So the first question is, what is the corrected red count? And I was going to put a bunch of these on, but then I realized we didn't really go over them in class, so I would just torture you with one. So corrected white count, not corrected red count. So my white count is 23.4. What am I going to multiply that?
100.
Am I done?
No.
What's next?
Divided by
Divided by what?
22.
Right, 122, which is 100 plus the 22 nervies. Okay, so my answer would have been 19.2 times 10 to the third per millimeter cubed. Okay. That was in the troubleshooting guide, and it's also there's also a worksheet that had how to do those. Or you can YouTube it. But that's how you do the corrected nervy count. Now, do we correct nervies for most of our analyzers these days? Yes, no?
Most of the time, the analyzer will remove them.
Most of the time, the analyzer will gate them out, so rarely do we do this anymore. But on some older ones, we will. Yes?
Is it, wait, never mind.
I can never mind. Are you sure? Okay. Yeah.
For the essay in the would you do an iron study because IDA would have deficiency in iron and thalassemia would
I
have.
don't remember. Hang on. I don't remember what questions I put on here. How do you differentiate between IDA and thalassemia? There's a dozen things. Iron package is probably the cheapest, the easiest. And FEP, the hemoglobin electrophoresis, patient history. The describe of hemoglobin electrophoresis, I am going to be very generous there. Anything that has the word current, standard, and compare in there, that's pretty much going to get it for you. Okay? And actually, I kind of broke one of my own rules, and that is I usually don't give you the answers anywhere else in the test. On these guys, actually, several of the multiple choice questions gave you clues to these essay answers. Describe one method of cell counting on an automated analyzer. Include reagents and characteristics. Again, I'm going to be very, very generous on this. Anything that is vaguely close to sort of, kind of what we do, whether you describe impedance and with resistance and cell size, or optical and light scatter. That's pretty much if you say either one, and then obviously diluent and lysine agent are the reagents I'm looking for. What's the first step of troubleshooting? This one should be easy. Is it turned on? Is it plugged in? Okay, that's number one. Explain the role of routine maintenance and troubleshooting. Again, very, very simple with this one. The role, I can go either one of two ways or both ways with this, that doing routine maintenance prevents problems, so you don't have to troubleshoot as much, and also that routine maintenance procedures are also the first things you usually try when you are troubleshooting an analyzer. So, if you're, especially in hematology, if you've got something wonky going on, the first thing you're going to do is run a clean cycle, see if you can flush out whatever little floaties are in there. Again, I'll be fairly generous on that. Okay? Have you pass them all back up? I will have them graded and back to you tomorrow morning along with last week's test.
What was the last week say? It was the last week cause it was.
Hang on just a second. What did you say?
What was the last thing cause for their last case study?
Oh, chemo related. Or no, I meant, what was the last one? Oh, the likely cause, sickle cell is the only one we've talked about that really would fit that one, but I'll take any kind of anemia that you wanna pop up with. What testing depends on, did you give me testing that is appropriate to whatever the heck you guessed? Okay? All right, Megaloblastics. The first class of anemias that we kind of talked about were the iron deficiency anemias. They're the ones related to deficiency or excess of iron. We also talked a little bit about secondary anemias, secondary to different disease states, right? The megaloblastics kind of hit their own. These are basically, if somebody says megaloblastic anemia, B12 folate. That's right where you're going. Megaloblastic anemias are a deficiency in B12 and folate, and or folate. They're associated with a defective DNA synthesis. So this type of anemia doesn't just affect your red cells. It affects all of your cells. Okay? Abnormal RBC maturation you're going to see in the bone marrow. We're going to have an asynchronous maturation. Our hemoglobin content of our cytoplasm isn't going to mesh with what we see in our nucleus. We're also going to see that it affects granulocytes and platelets, most notably hypersegmented neutrophils. Remember when we talked about chronic lymphocytic leukemia? And I told you there's a very classic picture. If it goes under your scope and you see lots of sort of all the same looking lymphocytes and smudge cells, it's CLL. It should slap you in the face and say CLL. When you're looking for IDA, we're looking for grossly hypochromic cells and not very many of them. When we're looking at megaloblastic anemia, we're looking at large oval macrocytes and hypersegmented neutrophils. This is why those hypersegmented neutrophils are significant. Now, does just one of anything matter? No. But multiple of those, we're going to notate that. Because a lot of times we're going to see the granulocytes affected before we see the red cells. Why? You got all the pieces for this puzzle. Why would I see my white cells affected before I saw my red cells affected? Because the white cell's lifespan is shorter. They're going to be replaced more frequently. My red cells, it might be a month or two before I replace a significant number of them to really start to see that megaloblastic picture. There are systemic effects of this impaired DNA metabolism. It affects all readily dividing cells. You're going to see skin problems, GI tract epithelial cells. A lot of times these people will come in complaining of diarrhea or abdominal pain, abdominal discomfort. Our hematopoietic cells are going to be screwed up. We're also going to see neurological problems. Shakes, jitters, abnormal gait, but you're going to have an abnormal neurological workup as well. All right. You're going to need to know all this by Tuesday. Hell no. All you need to know from this picture is that B12 and folate are cofactors in forming DNA. All right? You're going to learn the synthesis of DNA. You're going to do it in somebody else's class. You just need to know that B12 and folate are important to this, as is riboflavin, which is what, B2, B1? No, thiamine's B1. I know, it's one of the B vitamins. But these, and the vitamin B12 doesn't get used up. Okay? It can make whole bunches of DNAs before it's all gone. this is why they have pregnant ladies take folic acid before they get pregnant, because what human being is making more DNA than somebody who's creating a new human being, right? B12 and folate, or folate and folic acid, are used interchangeably, okay? Are needed for normal DNA synthesis and for utilizations of proteins and nucleic acids, okay? This is a macrocytic normochromic anemia. What is iron deficiency anemia? What category of indices does it go to? Microhypo. What about our thalassemias?
Normal. Micro and hypo.
They're microhypo. And what about our hemoglobinopathies? They're normal. But remember, because they are often ongoing, they will generally have a concomitant IDA, which means we'll see them present as microhypo. What I love is when you have somebody who's got iron deficiency and B12 folate, because you got great big ones and little bitty ones. So you got both. When we talk about treating these things and everything, they pretty much go hand in hand on how they act, but the causes and the way they work is a little bit, or the way they come about is a little different. B12 is bound by something called intrinsic factor. An intrinsic factor is a protein that is synthesized by the parietal cells in the stomach, and we'll see why that's important for just a moment. You usually have enough B12 stored in your liver for about 3 years. So this is not something you're going to quickly get deficient in. This takes some kind of long-term not eating your vegetables. We have a couple different ways that you can get B12 deficiencies. The first is pernicious anemia, and we'll talk more about that in just a moment. Dietary insufficiency. You just don't eat what you're supposed to. Okay? We find B12 in meats, liver, eggs, dairy. We'll see this one in long-term vegetarians or vegans who are truly don't eat eggs, dairy, or anything else. A lot of times they'll have to watch very carefully to make sure that they're getting organic sources of B12 or that they are supplementing with a vitamin. Biologic competition, and this is one that pops up on the boards every here and there. Diphyllobothrium latum is a parasite. It's a fish tapeworm. It's why you gotta be careful where you get your sushi. Don't recommend gas station sushi. No, that's not because of the tapeworm. It's basically you just want to be careful that the people who are preparing it know what they're doing and that the fish is sourced from a safe place. Okay. Gastrectomy or intestinal malabsorption. Patients, they had a lot of problems when they were first doing those obesity surgeries where they would cut the stomach till it was almost nothing. They had a lot of problems making sure they had got enough B12, because when you cut the stomach like that, you basically get rid of your intrinsic factor, and so you don't absorb things properly. And gastrectomy just means removal of the stomach. Folic acid. Folic acid is also absorbed in the duodenum and the jejunum, or the upper part of the small intestine there. The most common one for this one is increased demand. You don't have quite as big a store of folic acid. This one you see in leafy vegetables, broccoli. It's also found in fish. I might have to look and see what they are. Increased demand tends to be why pregnancy being number one. This is why you take prenatal vitamins. Alcoholism, and that's mostly because of interference in absorption. Cancers, anytime we've got a cellular proliferation, why would that cause a decrease in folic acid? Maybe because as we're making extra DNA for the cancer cells, the folate is getting used up. See, the B12 is just a cofactor. The folate actually gets used. Any kind of chronic hemolysis or malabsorption syndromes. Certain folate antagonist drugs. I don't know what the list of those is off the top of my head. Usually the best thing for that is they just give the patient extra folate. The other thing to remember, and this is a big one that we see frequently pop up on the questions, is hemodialysis. For some reason, the dialysis process decreases the folic acid, decreases the folate. I think the membrane that they use for osmosis and for filtering absorbs the folate. Okay, pernicious anemia. This is probably the most common of the megaloblastic anemias. It's a lack of B12, but specifically it's a lack of B12 because you can't absorb it. I can give you all the B12 pills in the world and you're just going to pee it down the drain, literally. Because your body cannot absorb it. So it goes in the stomach and you can't do anything with it. Okay? This is one that is actually most commonly found in those of Northern European descent, especially of the Scandinavian countries. It generally has an onset in patients who are over 40 years old. We see our general anemic symptoms. We'll also see gastric disturbances. They get upset tummies. We will see central nervous system symptoms. That's our neurological. Tingling or numbness. You know that when you sit on your foot and it falls asleep? Okay, that's what you're going to feel, only you haven't been sitting on your foot and it doesn't go away as circulation returns. Okay. Frequently a burning sensation, especially in the extremities. Yes.
You said the intrinsic factors of proteins, not the clotting factors in the intrinsic
No.
system, right?
No, clotting proteins are one kind of protein, hemoglobin's a kind of protein, this is another kind of protein.
What if you not sitting on your feet, like how we get those? Because sometimes I do get that tingling feeling like in my feet.
I don't know.
That's crazy.
I don't know. Hematologic findings, we're going to see macrocytic anemia. Macroovallocytes, it means oval macrocytes, not round ones, oval ones. And the reason I say that is when in anemia of liver disease, we're going to see round macrocytes. So if I ask on the test, how do I tell the difference between the two? I got oval macrocytes in the megaloblastics, and liver disease tends to give me oval or round macrocytes and target cells. Okay. So if I'm looking at anemia secondary to liver disease, it is macrocytic, but usually what I see is round macrocytes and target cells. I'm going to see hypersegmented neutrophils. There's going to be an increased reticulocytosis. Okay, the body is trying to make these things. I'll see normal to decreased white cells and platelets, and this is usually not horrendously low, but they will be slightly decreased. In the bone marrow, I'm going to see a hypercellular erythroid hyperplasia. I'm going to see lots of cells, but I'm not going to see enough red cell precursors. I'm going to see a megaloblastic picture. Nuclear cytoplasmic asynchrony, the nucleus lags behind in maturity. I'm going to see stage 1 and stage 2 erythrocyte precursor nucleus that have already got a red cytoplasm. So I'm going to see a severe lack of cohesion between the two. Normally the nucleus progresses and the cytoplasm just tags along. Well, in this one the cytoplasm keeps going, but the nucleus isn't doing what it's supposed to do. The other thing that's associated with megaloblastic anemias, and this is kind of another one of those big clues, is within the bone marrow I'm going to see giant metas and bands. Okay. By the time it gets done with its myeloproliferative, it's my leukopoiesis, I'm sorry guys, By the time it gets done with leukapheresis, it gets down to those last two stages. Normally the cells have shrunk. Well, on this guy, because it's not working correctly, the cells are still very, very large when we get down to the, say, advanced stage. Yes?
Does that keep them from being moved out?
No, they move out. They ooze through the sides just as well as they always do. Yes?
The nucleus doesn't mature correctly and the things are dying probably with the DNA, right?
Right.
And that's what's the purple. And since immature cells, the DNA is extra large. Yeah.
Right. Now on the leukopoiesis, we don't see the same asynchrony. It may lag a little bit behind, but the asynchrony is much more notable in the red cell precursors than in the white cells. Okay, other lab findings. The old test we used to diagnose B12, to diagnose intrinsic factor, pernicious anemia. What we did, I'm gonna tell you, then we'll read it. Okay. Well, what you do? Somebody thought it'd be a really good idea. We take some vitamin B12 and we make it radioactive. Woohoo! Hey, in the 70s or 60s, 50s and 60s, they made everything radioactive. They thought that was the answer to everything. Okay. So they made the B12 radioactive. Then what they did is they gave you the pill with the radioactive B12. Okay. If you have intrinsic factor, your body is going to absorb that B12, right? Smile and nod. If you have intrinsic factor, your body's going to absorb it. What's going to happen if you don't have intrinsic factor? You're going to poop it out. You're not going to have absorbed it. Okay? It's just going to go straight through the GI tract. If you have intrinsic factor, and I catch your pee, it gets filtered from the blood through the kidney. So if you absorb the radioactive B12 because you have the intrinsic factor, it entered your bloodstream, which went to your kidney, so you pee it out. So what we do is we collect your pee for 24 hours, and we measure it for radioactivity. Okay, given that explanation. If you have pernicious anemia, which is a lack of intrinsic factor, will your pee be radioactive? No. If you do have intrinsic factor, your pee will be radioactive.
That just seems slightly stupid and dangerous. You're
Well,
putting a
dying from pernicious anemia is worse.
but you're poisoning yourself to see if you even have it.
It's not that high of a
There's no-
radiation dose. You probably get more radiation going through the scanner at the airport. It's a very low radiation dose. Very low. So that proves that we don't have any intrinsic factor. Gastric analysis, I don't know why you would do this on a living body. This is something they usually do in autopsy. Confirms that there's confirms achlorhydria. The acid in your stomach is 7 normal hydrochloric acid. So if we check your stomach, you won't have enough acid. You're going to see an increased bilirubin and LD due to intramedullary cell death. Hang on to that information, it'll pop up when we head through the numerics. Okay? So these are some other lab findings that we see. Oh, good Lord, I didn't update this one? No. This like, do we do the Schilling's test anymore? No, not a whole lot. Why? Because we have pretty much found out that pernicious anemia, you're going to need to write this down because I don't have it down. Because pernicious anemia is autoimmune in many cases. Things like gastrectomy will give it to you, but that's aside. But most cases of pernicious anemia are autoimmune. So instead of looking for radioactive pee, even though it's fun to make things glow in the dark, you know. So instead of looking for radioactive pee, what we do is we check for something. Called an anti-varietal cell antibody. Because many of these, or most of these pernicious anemia cases are autoimmune, what that means is that for some reason in these patients, the immune system has, and we'll talk a lot more about autoimmune disease come fall, but for some reason your body has decided that your stomach is a foreigner and needs to be attacked. Okay? So what it does is it attacks these parietal cells. It keeps them from secreting intrinsic factor, which means you don't absorb B12. That's a simple blood test. I can do it off of a SST tube with dozens of other tests. It's a lot easier than collecting 24 hours worth of pee. A lot less stinky.
Does it affect your blood cells? Because they're the ones attacking.
Yes and no. Can I leave that discussion for when we hit autoimmune? Treatment? Well, if they're vitamin deficient, what's the best thing to do? Give them vitamins. You basically cannot overdose on the B vitamins. You just get really expensive P. Your body will take what it wants and just flush the rest. The thing with pernicious anemia, I can't absorb B12. So I can pop all them B12 tablets I want, and what's going to happen? Nothing. So what I'm going to do is I'm going to give you B12 injections instead. I'm going to bypass the stomach entirely. They're relatively inexpensive, depending on a lot of other factors. If you're healthy other than the pernicious anemia, about every 3 to 5 months. If you have something else going on, maybe once a month. But you just go into the doctor's office and they shoot you full of B12 and you move on. Remember, your liver stores it. So, if you take it orally, your body just gets rid of it. But your liver will store a fairly goodly amount of it. So if you just go in once a month or so, they pop you with a B12 shot and life is all happy and hunky-dory. Folate will be given as an oral medication. That one's not given by injection. They usually are going to treat it with iron as a supplement just because you're going to have increased hemoglobin production until you get caught back up. The pernicious or the megaloblastic anemias don't tend to be as low as your iron deficiency. Remember, our iron deficiencies, those can get down in the below 5 range. It's slowly, it's insidious, but these, somebody with an iron deficiency anemia will get way down. The pernicious anemias, they tend to stay in the 7 to 10 range. But remember, people's bodies don't read the book and they'll do things that just confuse us. But for the most part, iron deficiency is going to get to be much more severe if untreated than the B12 and folates. That's megaloblastic. That's the easy one for the week. Okay. I'm going to take a moment since I've got a little bit of time to kind of map out what we're going to be doing for the next week. Nicole, you're going to train Katie. Katie, you're going to train. Pick one. CLM. You're going to train her, okay? So when you're done, you're going to train her. When she's done training you, you're going to train her today. You're going to train her today. Tomorrow, you're going to train somebody else, and whoever you train is going to train somebody else. Okay? Eventually, we'll get through all of you. So that's number one, is we do wanna make sure we get all of that training in. Number two, what I wanna do in lab today is I'm going to pull up a CML. I've got some lovely CML slides, and we're gonna go through one on the screen together, just like we did the last time where we all counted the same one. See how close we get this time with a little bit harder one. The thing with our CMLs, they are usually more than 100 cells. So, in order to get a good statistical distribution, I have to count more cells. If my count is greater than 35, I count 200 cells. If my count is greater than 75, I count 400 cells. So on almost all of these CMLs, you're going to be counting 400 cells. Now, before you freak out, remember the ones you've been doing have counts between 5 and 10. You might have gotten as high as a 20. Okay. In a CML slide, you're going to have 10 or 15 cells per field. So it's not like going, oh, there's one. Going, oh, there's one. It's more like, and I got that one, I got that one, and that one, and that one, and that one. What I do when I count my 400, because, why did I just say we count more than 100? Say it again.
There's more white cells.
There's more white cells, but why, what does that matter? Why don't I just count 100 of them?
Distribution.
Distribution, statistical distribution. If I've got a larger population, I probably need to sample more of them. And the other thing is they tend to kind of cling together. If you've got a little clump, it might have 5 milos, and you'll get another little clump, it'll have 5 or 6 metas. So they tend to not distribute real smoothly. So what I do when I count them is I count 100 cells, then I move to a different area and count another 100, and then I move over a field or two and count another 100, and move a field or two and count 100. So how do I report my results?
Divided by 4.
I don't report it as 4 times. I don't report, 92 sags and 53 bands and 61 metas. No. Okay, I have to report it as a percent. So all I'm going to do, if I count 400 cells, I'm going to divide by 4. But if I count 200 cells,
Divide by 2.
I'm going to divide by 2. What if I have a really low count? If I have a count that's less than 2, I only count 50 cells. What am I going to do to report that one?
Multiply by 2.
Do I need to do those on the board, or can you guys figure those out? Okay, those are going to be on the next test. That's going to be some of the easiest points you're going to earn this semester. Okay, I did a 400 cell dip. These are my answers. What would I report? Now, the only little glitch to this thing, what does your answer have to add up to?
100.
100. So what happens, when I get my multiplying out and I add it all up and I got 101? I just get rid of something. I just get rid of something. Does it really matter? Because diffs, are they about numbers? What are they about? Ratios. Is the difference between 1 length and 3 lengths going to make a difference? Is the difference between, 20 metas and 15 metas? No. You got lots of metas. Okay? So throw one out. What if I'm missing one?
Is there some, because I had that problem too when I was calculating. It was one of the problems on the examples where it was like 82.5 and the other one was like 2.5.
You gotta round.
Yeah, round them off.
You're gonna round them off, and if it's off by 1, you're gonna throw 1 extra in there. If it's up by 1, you're gonna get rid of 1. If it's down by 1, you're gonna throw 1 in there. Okay? It isn't gonna, but you're gonna put them out so they report out to 100. Okay? Yes, technically you could report 88.5 and 2.5 but we're just gonna take them to whole numbers. Makes it easier on us when we're counting, because we don't count half cells. Alright, so does that calculation make sense to you? I'm gonna see if I can find a CLL slide. I'm not sure if I have one or not. I'm going to be a few minutes because I'm going to take your tests up to the ladies upstairs to grade them. And then I believe I need to go to the car because I don't think I brought my nice new CLL slides in.